I would like to thank you very much for organizing this. It's amazing to have 501 people connected to listen to these very important messages. I especially want to thank our patient representatives, Ken and Verla, for sharing their stories, very important stories. And one of the things that are going to be, that resonated a lot was what Ken mentioned. Everybody's diabetes is different. And I think a lot of what I'm going to be kind of presenting now has to do with that it's not, and Chantal has also reiterated that it is not one disease, it's a disease or a monster that has many, many faces. So as I said before, I've been very much involved in IMI Summit, which started, it was one of the first IMI projects, started in 2009. And then I'm currently leading BTKD. But apart from that, I've chosen to pick up and to give some highlights from these other IMI projects, Immediate, Direct, Rhapsody, and Sophia. And there is some kind of a chronological order in the way they're accommodated in this slide, because there are many teaching lessons from these projects, and I hope to be able to share some of them with you. The reason why I picked these ones is because many investigators at our Lund University Diabetes Center have been involved, so I've been exposed a bit more to this consortia, and therefore I feel like I can share some insight. But it's absolutely not to neglect the efforts of other consortia. We've heard Chantal presenting about Inodia, and we also know that there are 17 consortia organized by IMI that are centered on diabetes and metabolic diseases. So this is absolutely not to ignore or not acknowledge efforts done elsewhere. So just as a reminder, IMI is about accelerating things. It's about making things faster, to speeding up patient access to all the novelty that we are generating, and also to make sure to improve patient outcomes and safety of medications. So there were the first generation of IMI projects were very, very ambitious. They set up to deliver biomarkers and tools to be able to follow disease progression a lot better, to be able to identify which patients were going to get sick and how disease was going to progress on them. And it was a very ambitious goal. And immediately after launching in 2009, Immediate was slightly a year later, and then Direct a couple of years after. These consortia, we realized that there were serious bottlenecks. And as much as scientists had always acknowledged that in order for us to fight diabetes and to be able to tackle all the issues that we want to resolve, we need to work together. From that idea and ambition to reality, there was a big, big gap. So I would say that at the time when we started Summit 2009, a lot of what was going on was happening in isolated silos. There were several exceptions to that. I would say, so I've always been very impressed by the area of genetics, in which Emma and Emma collaborators operate, because geneticists are very, very early on realized that they needed numbers, they needed power, and therefore they started building consortia long before everybody else reacted to that concept. But when we started in Summit, there wasn't much going on in terms of working together in all other areas that are also important apart from genetics. So a lot of the very early years of these IMI projects went on to solve those bottlenecks. We weren't harmonizing the way we were doing research. We weren't collecting samples in the same way. We weren't analyzing the samples either. At the same time, there was this explosion of omics techniques that was popping up at the time. And we weren't really in agreement of which technologies were the best ones to use. So there were lots of considerations to take into account. And apart from that, it was the first time we were working on public-private partnerships, but not only on a one-on-one basis. We were many companies sitting around the same table, and we also needed to start talking the same language. So that took some time. The second generation of IMI projects, the ones I have on the right side of my slide, Rhapsody, BTKD, and Sophia, they were in a much better position when they started, because lots of these bottlenecks have been solved, and it was more a matter of doing an efficient harvesting of all the efforts that have been invested early on. So it's been less of headaches and a lot more pleasurable experience, I must say. There's still lots of challenges, and we can lift up now our head and start dealing with other kinds of things. So I hope I will be able to give you a bit of highlights of what has been done in these projects, what has been achieved. And I want to focus on some specific topics. One is the power of public-private partnerships in diabetes research. I must say, after being involved since 2009 in these kind of partnerships, I'm certain 100% that we wouldn't have achieved what we've done if it wasn't in this setup. I think it was, as I said before, we were traditionally used to work with industry, but maybe on a one-on-one basis. But this was the perfect forum for creating a place where we could all talk without worrying about IP or patents. We could all benefit from these conversations. And it was very clear that as long as we define what's in it for me in this partnership, we were all on board and we were all pulling on the same direction. So that was one of the very important things. Plus that there was a lot of complementarity between the different areas. So the private sector and academia had different expertise. The strengths were differently. So it was a very good match, especially when it came to make things available. In academia, we were used to do discoveries, but we very rarely pushed them all the way to make them approved and qualified for being used in the clinics. So that was also very important. Then the other concept is, during these years, we've been all acknowledging, again, that diabetes is not one disease. And we will hear more from Emma. It's a project that was run together between BTKD and Rhapsody, in which we have a clear example how we are able now to identify patients that have different disease progression and respond differently to treatments, and how this is critical to be able to deliver the right prevention and treatment to the right patients and at the right time. The other point I want to make, and if there is time, we can talk more about maybe in the question session, is that I think thanks to the IMI projects and this change in the way we work and in the way we can make things happen faster, I think we were a lot more prepared when the COVID pandemic appeared. Many of us, I mean, life has been different during this last year. A lot of the work that we were used to do had to put on hold. And in the meantime, we were thinking, what can we do to help? And I think this goes beyond the area of diabetes. It has implications for diabetes because the COVID pandemic has also striking differently patients with diabetes as opposed to the rest of the population. But I also think there are learning lessons, and the way we could shift resources and allocate resources and the preparedness that we had in terms of dealing with ethical and legal issues helped us very much to deliver something that was useful and very important during the pandemic. And if there is time, we could share those experiences as well. When it comes to Summit was about diabetic complications. It was about monitoring changes that take place on your large and small blood vessels, changes that are the basis or the underlying reasons why patients with diabetes have a larger risk to suffer from heart attacks and stroke, and also from blindness and loss of limbs and kidney failure. So what Summit was able to deliver, even though there were a lot of hurdles at the beginning, were some genetic markers and soluble biomarkers that were able to track disease progression, especially in the areas of cardiovascular disease. Summit also delivered novel imaging techniques for monitoring disease progression, especially in atherosclerosis and retinopathy. And also another of the limitations that the field of complications have been struggling was not to have animal models that really replicate the disease as we've seen it in humans. So Summit could deliver some of those models that are still now in use. And it was also one of the first times in which we started kind of cross-fertilizing with other disciplines to do more in silico methods for modeling and predicting diabetic complications based on data that had already been accumulated. At the same time, during those years, IMI was working super intensively to circumvent another bottleneck. We knew a lot about the pancreatic beta cell in animal models, but we knew quite little. There were severe limitations in our understanding of how the human pancreatic beta cell was working. And IMI put a lot of effort in delivering tools that allowed us to understand that better. And Direct was very curious because Direct from the very beginning understood that if we were going to be able to answer the question about heterogeneity in diabetes, we needed to have trials that were a lot more detailed and more detailedly phenotype. I won't go through all these details. There is a lot published in the Direct Consortium's webpage, but just to give you a bit of a flavor, they set up two cohorts that still today are being mined and explored, and are a fantastic resource to understand the heterogeneity of pre-diabetes and type 2 diabetes, with participants from all across Europe, and very deeply phenotyped with both imaging, measures of lifestyle and physical activity, diet records, and a lot of other pieces of information that had led to groundbreaking publications describing, for instance, biomarkers of glycemic deterioration, among other. There's still a lot in the pipeline coming out from Direct. Another reflection, because we can make, luckily we have access to metrics, we can measure our impact. And when IMI turned 10 years in 2018, there was a sentence that was quite interesting after doing a lot of analysis of how the publications have impacted. The citation impact of IMI papers is twice the world average and significantly higher than the EU average. I think that tells us that work that is being produced by IMI projects is appreciated by peers, is cited, is used, is been generating value. If I move and I give a couple of examples before giving the word to Emma about BTKD and Sofia, what I want to emphasize on BTKD is that we put a lot of focus on validation of previous discoveries. And why is this important? A lot of the data that has come in the past years has been very Europe and US centric. Lots of the clinical trials and observation cohorts that we've used have been from Europe and the US. And there are questions about how these results can be generalized to other populations. So we've been putting effort through collaboration with different consortia all around the world to make sure that our findings are translatable even in populations of other ethnic origin. And that has also helped us very much to circumvent other bottlenecks, like Chantal touched upon that, the sharing data and samples across Europe, it is difficult. Imagine sharing data and samples across the whole world, where there is differences in legislation and privacy and the way we handle data. But we managed to put a system in place in which we can federate the data, we can share sensitive data without revealing sensitive information, and still be able to interrogate and ask relevant questions. So the last piece that I want to emphasize from BTKD, a learning lesson, is that this is a slide that I normally use to highlight imprecision medicine. Imprecision medicine, this slide just shows you for every person that a medicine helps, the little persons in blue, there are at least 3 to 24 people in red that are not helped by the drug, and they're still receiving it. And these are the 10 highest grossing drugs in the United States. The situation is not much different from drugs that we're using for treating diabetes patients. When we started in BTKD, ACE inhibitors were there available since 1993, angiotensin receptor blockers. That was what we could offer patients with diabetic kidney disease. And it was great. That was breakthrough findings, because we can reduce and slow progression of renal disease by 20% compared to the standard glucose lowering and blood pressure lowering therapies. But there was still a lot of residual renal and cardiovascular risk. It was very high. And it's only recently, I mean, 15, almost 20 years later, that we have a little bit more to offer to diabetic kidney patients with the discovery that endothelin receptor antagonists, atrasentan and sodium glucose co-transporters, two new types of drugs that can help DKD patients. But still, we know that not all patients benefit from the same treatment. We need to abandon the idea of one size fits it all. So in BTKD, we've been putting a lot of efforts in developing and identifying biomarkers that can tell us, before we start exposing a patient with a medication, whether this patient will respond to it or not. So that saves a lot of unnecessary treatments, it saves cost, it improves quality of life. So we are very, very confident that with the methods and techniques that we have in place, we can do this for many of the drugs that are currently being used instinctively to everybody that has a diagnosis. And last but not least, and this is just to re-emphasize how the IMI projects have also learned a lot throughout. And Sofia, which is the youngest of them, it just has 1 year of age, is putting a lot more emphasis on having and measuring patient-centered outcomes. There's a lot higher involvement of patients in this project. And I think this is something that we're going to be seeing more and more often, and it is absolutely necessary. So we should start talking about many more pieces, public, private, patients. We all need to be on board to solving this. And with that, I will skip the COVID slide in the interest of time, and I will leave the podium to Emma.